Dr. G, I so appreciate your
My
care.
pleasure.
And Dr. G is the head of infectious disease at Scripps, and he's the kindest doctor, one of the kindest doctors I've met. And he's just explaining to us why he thinks this is low risk for aspergillosis, and about to show us some pictures.
Yeah. So, I mean, so kind of, just take a step back and say, who gets pulmonary aspergillosis? And it's going to be two patient populations. One that have very severe lung disease like emphysema in the setting of steroid therapy. The amount of steroids that you have, they can get chronic invasive aspergillosis that slowly grows over many months. They cough, cough, cough. It's a low-grade chronic pneumonia, occasionally have hemoptysis. And they get it, the steroid therapy helps, but it's really the scar tissue, the poor vascular supply that really sets them there. The other groups of patients get something called acute invasive pulmonary aspergillosis, so normal lung tissue, but they're very severely immunosuppressed. And so if normal populations, there's some fluctuation up here. You got pneumocystis, pneumonia here. Typically, people that are getting acute invasive pulmonary aspergillosis are usually lung, bone marrow transplant patients early, or very neutropenic patients, really with no neutrophils for a couple of weeks, usually longer. And they'll start getting it. The symptoms, typically asymptomatic, sometimes just fever, and they start to get nodules. So it can look like that can cavitate. So it makes everybody worry, about that. So the CT findings, earlier on, certainly concerning, but you are not in that spot. We also have an alternate diagnosis. So now objective data, we have pneumocystis, and how do we diagnose aspergillus? So right patient population, so you don't fit in there, it doesn't mean you can't get it. And then trying to have indirect and direct measurements of the presence of aspergillus. So on the first set of bronchoscopy, they looked for galactomannan, they looked for DNA, and they did fungal cultures, all three negative. Moving forward in time, they treat you, you're on a little, I think a little bit less Decadron. Pulmonary nodules are improving, and then we get another bronchoscopy, this time mostly to make sure that we're not having malignancy in this biopsy. The biopsy, I suspect, is probably sampling error. It shows nothing. It shows normal tissue. I think it's sampling error. So not useful. The bronchoscopy here, we have fungal cultures, still early, negative. We have a galactomannan, which measures sort of an antigen on fungal walls. It's negative. And then DNA for a aspergillus species positive, but the fumigatus, which is the aspergillus, is the more aggressive species, negative. So based on that, it's not sufficient information, sufficient evidence for it. Not quite the right host. The direct findings, most are negative. One, the specificity of it being positive is somewhat low. So I think that, and then importantly, without treatment, things are getting better and smaller. So let me actually bring that up. So I think it's low probability, but we don't fully have an explanation for what these nodules are, and I think we should still do some more investigation. Could it be pneumocystis? Yes, it's just nodules are unusual. Not impossible, it's just unusual. That would fit, and you just have one thing. And so that's probably the case, but it's not something when I see nodules, I typically think of pneumocystis. So we'll look for other fungal infections, which it may be unlikely to be. but ones that are more likely for people to have, which is valley fever. You don't have to have immunosuppression for that. We get that. It's coccidioidomycosis. And then also cryptococcoses. You're not receiving treatment for those. So where are our nodules? There they are. Right upper lobe. And these guys are smaller than before. So on the left and the right. So these guys have shrunk by about 20% from the last ones.
Right.
And then the rest of the lung part looks okay. Yeah, going through. And then what you had before, so they compared it to, I don't have them at the same thing, but compared to what you had before. So previously 2.2, 1.8, 1.4, 1.1, 1.2, 0.9, 0.9, 0.7. So decreasing, with time. If we go back here, this is an earlier one. There's some of these nodules here. It's so if you don't mind, I put. This one's a little bit bigger. So these have gotten smaller. And so the only thing we've treated is pneumocystis, but this CT scan going back here or even here in June, is not
So
it's not the typical presentation for radiographic presentation.
Dr. Escobar,
I think he was probably surprised to find the pneumocystis there.
yes.
We have some haziness here, and that might be it. So possible for two things, This is a contrast. I think they're looking for pulmonary emboli. So, we have pneumocystis. Atypical that they might be the nodules, but that's something we're treating, and they're getting smaller with time. I think very unlikely aspergillus. I would not recommend the voriconazole.
Yeah.
But what I would do is a little bit more investigation, and with blood work, I would, how we diagnose it is we also look for surrogate markers, so fungal markers of beta-D-glucan and galactomannan in bloodstream. It's similar to what he did out of the bronchoscopy.
Yes.
Bronchoscopies are generally more sensitive because you're in that area,
Yes.
And then also I'd broaden it out and look for what's called cryptococcus and what's called valley fever coccidioidomycosis. Yeah. Those things are, again, you're not being treated for that, and would argue against those things are just resolving on their own. But you don't have to be immunocompromised to get those, or if you're even just more moderately immunocompromised, those can cause issues.
And how would you
yeah, it's a blood test.
Yeah.
Yeah, it's a serology and one that's looking for antigen. So all of those 4 tests, it's a blood test. No procedure.
And you would follow along with chest CT.
Yeah, as you got chest CTs are going, they're going to, because we still don't know what these are, and so following the chest CT, intervals would be useful. If the blood tests aren't positive. But for right now, for today, based on the information that I'm looking at in your history, I don't think we have enough evidence to recommend. I have very low clinical suspicion for aspergillus.
Yes.
If it was more in the moderate area, then you start going ahead and doing empiric treatment. But I think it would not be of benefit.
Can you convey this information to Dr. Beaumont?
Yeah, absolutely. Is he your surgeon or oncologist, or who is?
I'm my neurosurgeon.
Your neurosurgeon? Yeah.
So I want to thank you.
My pleasure.
Yeah. And blessings.
Can I switch?
Yes. Yes.